Hello everybody, I am Dr. Mervet, Professor of Internal Medicine and Rheumatology in Shams University. Welcome to the presentation of part 1 of lecture Osteoarthritis. Osteoarthritis is a common form of arthritis that presents as bone-articular disease. First of all, our intended learning outcomes. By the end of this lecture, the student should be able to define osteoarthritis, understand risk factors of the disease and its pathogenesis in brief, classify the disease as primary and secondary, learn the clinical presentation of this disease, diagnose and select suitable non-pharmacological and pharmacological therapy, or advise surgery for the patient. Now, what is osteoarthritis? It's degenerative disease of joint characterized by progressive loss of articular cartilage accompanied by proliferation of new bone and soft tissue in and around involved joint. Regarding the prevalence of osteoarthritis, the prevalence of osteoarthritis rises progressively with age, and it has been estimated that 45% of all people develop knee osteoarthritis and 25% hip osteoarthritis at some point during life. The lifetime risk of having total hip or knee replacement for osteoarthritis in someone aged 50 years is about 11% in women and 8% in men. The increased incidence of osteoarthritis in women has led to speculation that sex hormones may play a causal role, while there is no evidence to suggest that circulating sex hormone level or reproductive history predisposed to osteoarthritis. Regarding risk factors for osteoarthritis, the prevalence of osteoarthritis increases with age, rising from 1% in those under 30 years to more than 70% in those over 70 years of age. Obesity is a significant risk factor for the development and progression of osteoarthritis, particularly osteoarthritis of the knee. Females are more prone to osteoarthritis. More joints are affected in women. Frequently, patients with osteoarthritis will have a family history of the disease, and there is often a similarity in the type of osteoarthritis that develop among family. Metabolic disorders like hemochromatosis and ochronosis are also risk factors. Joint injuries due to trauma or as a result of repetitive occupational and sport activities are also strongly associated with osteoarthritis. Finally, congenital joint disease like femoral epiphyseal dysplasia are also risk for osteoarthritis. The main principles that determine development of osteoarthritis are either extra loading to normal joint or normal mechanical load applied to abnormal joint and cartilage. Both produce osteoarthritis. This leads to the clinical classification of primary osteoarthritis, where no underlying disease process, and secondary osteoarthritis to underlying disease. Regarding the pathogenesis of osteoarthritis, major alterations in cartilage structure are characteristic of osteoarthritis. Chondrocytes divide to produce nests of metabolically active cells. Initially, matrix components are produced at an increased rate, but there is increased degradation of cartilage components, including aggregates and type 2 collagen. Fissuring of cartilage surface, localized chondrocyte death, and decreased cartilage thickness then occur. Continuing pathogenesis, calcium pyrophosphate and basic calcium phosphate crystals often become deposited in abnormal cartilage. Subchondral bone is also abnormal, with osteosclerosis and subchondral cyst formation. Fibrocartilage is produced at the joint margin, which undergo ossification to form osteophytes. The synovium undergo variable degree of hyperplasia and inflammatory changes observed. Actually, the degenerative process not only affects the cartilage but also affects subchondral bone, ligaments, capsule, synovial membrane, and periarticular muscles. This image illustrates The gross pathologic findings in osteoarthritic knee joint with cartilage loss with narrow joint space and direct friction of articular bone, marginal osteophytes, and sclerosis in subchondral bone. The most common symptom of osteoarthritis is pain, which is characterized by being insidious in onset over months or years, variable or intermittent, mainly related to movement and relieved by rest, with only brief morning stiffness and brief gelling. Usually, only one or few joints are painful. Clinical signs of osteoarthritis include restricted movement due to capsular thickening or blocking by osteophytes, palpable, sometimes audible, coarse crepitus due to rough articular surface, bony swelling around joint margin, deformity, with or without instability, joint line or periarticular tenderness, muscle weakness and wasting, synovitis, very mild or absent.